From afferent to efferent, creating a new pathway. This case is of a 35-year-old female who underwent a Whipple procedure for a pancreatic neuroendocrine tumor who presents now with progressive nausea and emesis over the past year. Her post-operative course was complicated by complete mesenteric thrombosis requiring a Segura procedure. A CT scan of her abdomen and pelvis was performed. As seen here, there is a massively dilated afferent loop coming from the gastrojejunectomy. The patient underwent upper endoscopy, demonstrating a widely patent afferent limb and stenosed efferent limb. Upon further review of the imaging and after traversing the stenosis, it was determined this obstruction was due to extrinsic adhesions and not recurrent tumor. The patient has been TPN dependent and due to her previous surgeries not felt to be a surgical candidate. After failure of numerous balloon dilations, she was referred for consideration of EUS-guided afferent limb to efferent limb anastomosis creation. Upper endoscopy here depicts the massively dilated afferent limb with copious amounts of pooled bile. At this time, contrast is injected to outline the afferent limb on fluoroscopy. The endoscope was then redirected and balloon dilation of the afferent stenosis was performed using a through-the-scope balloon dilation catheter. This was done to facilitate passage of the linear echo endoscope. Subsequently, a guide wire was advanced deep into the efferent limb and confirmed on fluoroscopy. At this point, the upper endoscope was exchanged for the linear echo endoscope over the guide wire. The echo endoscope is carefully negotiated through the stenosed efferent outlet. Linear endosonography reveals a massively dilated afferent loop abutting the efferent limb. Contrast in fluid is appreciated here within this dilated limb. At this time, the electrocautery-enhanced EUS-guided Lumen Apposing Stent system was introduced through the working channel and locked at the scope hub. The needle, as seen here with the large arrow, is introduced and identified on EUS. After Doppler assessment for intervening vasculature was negative, electrocautery-assisted puncture of the afferent loop is performed. For safety, a hydrophilic guide wire is advanced and coiled within the afferent limb. At this time, the internal aspect of the Lumen Apposing metal stent is slowly deployed by pulling back on the stent deployment hub until it locks in place. This is visualized here on endosonography. At this time, mild back tension is pulled on the stenting system. The echo endoscope is then slowly withdrawn to visualize the stenting system endoscopically with subsequent deployment of the luminal side of the Lumen Apposing stent, as seen here. There is immediate drainage of afferent limb contents into the efferent limb. A successful anastomosis has been created. This is confirmed fluoroscopically as seen here, with communication between the afferent and efferent limbs. At this time, the upper endoscope is reintroduced to confirm proper positioning of the Lumen Apposing stent. Initially, the efferent outlet is entered across the stenosis as seen here, and the endoscope traversed until the Lumen Apposing stent is identified. Again, large amounts of afferent limb contents are seen draining through the stent. The position is confirmed endoscopically and fluoroscopically. Finally, the afferent limb is subsequently entered, and again the Lumen Apposing stent is identified as deployed successfully, both endoscopically and fluoroscopically. Final confirmation of fluoroscopy is seen here. The patient had immediate resolution of her symptoms. At 2 months post lumen opposing metal stent placement, she remains symptom-free and now is off TPN. She is to return at the 3-month follow-up for lumen opposing metal stent removal. EUS-guided lumen opposing metal stent placement is feasible in patients with post-surgical outlet obstructions. Placement of lumen opposing metal stents is an effective option for afferent limb decompression when surgery is not feasible. EUS-guided anastomosis should be performed only after multidisciplinary discussion with the surgical team. Proper patient selection is essential. In conclusion, this case highlights the use of lumen opposing metal stents for effective decompression of an afferent limb syndrome due to an efferent outlet obstruction.